Hello, everyone, and welcome to another episode of our Wemcast podcast. As always, I'm one of your Wemcast hosts, Dr. Shawna Pandya, general practitioner from Canada. And today we are going to talk about living the extreme medicine life with Dr. Johannes Svensoy, an avid mountaineer with an impressive background in humanitarian medicine, expedition medicine, a skydiver, a rescue diver who has been across all domains from working on the Thai-Burmese border, tackling difficult issues in men's health, to working on biosensor technology during his PhD in the COVID era. So we have a lot to talk about. Johannes, thank you so much for joining us. Welcome to the podcast.
Thank you very much, Shawna. It's a delight to see you again and talk to you again. And thank you for the nice introduction.
Yeah, I can't wait to dig into it, but let's start at a high level. So you have this incredible background in disaster, tropical aviation, offshore, humanitarian, expedition medicine. Like if there was a tick box or bucket list for expedition and extreme medicine, I think you would have hit all the domains. How did you get started in this?
Oh, yeah, wow. Thank you. Where did it start? That's a good question. I believe things kind of evolved through my medical career, or even before that, I had a very broad field of interest from art to space. And as I say, I was doing mountaineering, kayaking, diving, parajumping, and also love to travel and meet new people, learn about other cultures. And I think I brought this broad field of interest into medicine. And that leading me to a specialization in disaster medicine and doing humanitarian work and getting trained in aviation and offshore medicine. So
go ahead. Yeah.
No, I just remember that one of my best and early advices for choosing specialty was to define how I wanted to work rather than just focusing on what I wanted to work with. So medicine is a lot about choosing fields, right? So instead
Absolutely.
of setting up hematology against surgery, and this is my advice to med students and others as well, like think how you are as a person. Like, are you a thinker? Are you a doer? Do you want action? Do you want to do the kind of detective work, diagnostics? Do you want to work daytime, night shifts? In hospital, pre-hospital? You want to be a specialist in one field or a generalist? And this kind of led me into emergency medicine kind of quickly, having the broad interest field and also being able to both work in hospital and pre-hospital.
And was there ever a conscientious point, even before going into medicine, saying, hey, I'm fascinated by medicine, the ability to do good to people in a vulnerable position versus I know I'm an adventurer at heart. You said you were a kayaker, mountaineer. Did you ever make that conscientious decision before you got into medicine to say, hey, maybe there's a way to combine the two?
Well, yeah, absolutely. Actually, medicine wasn't my first field. Having parents coming from total other fields, I didn't know much about the health aspects. So, but I knew I kind of wanted to do good. I have that kind of want to help others gene from my mother. So I started out with studying law, and I found out I wasn't especially good at that. So my job would probably just staying there stamping papers rather than actually being able to do something. So that led me into, I first did nursing, worked for a few years, and then did medicine, and I would never do it differently.
Now, I want to hone in on one of your specific experiences. So when we first met, you told me about your experiences and adventures working along the Thai-Burmese border, and then specifically doing some very important work and publications with respect to a little-known men's health issue. So tell us about that. How did you get involved, and how did that end up growing?
I have a very good friend here in Oslo, which with family from Myanmar. So I've been following the kind of conflict there since around 2000 up against to the demonstrations in 2007. And Myanmar has this kind of extremely dark history with dictatorship and oppression for the last 60 years. And it was 2012 I first traveled over, and I've been over about 4 times after that, and mostly working at the Ma Tau clinic, which is a small rural clinic on the Thai-Burmese border, mostly providing free medical help for Burmese inside Thailand and some coming over the border, and for the refugee camps along the border, which there are a lot of, unfortunately. So we did some outreach medical expeditions into the villages, doing some surgical outreach, but mainly we were doing, or I was in the trauma surgical part of the clinic, caring from everything from burns to infections, motorbike accidents, mine accidents, etc. But this one thing I remember, which we should take up, is the penis injections, which is this practice of self-injecting oil, usually coconut oil or palm oil, into the subcutaneous skin of the penis, so along to make it larger, not longer. And this, I never heard about this before when I was there, so I was kind of curious. And throughout the times I was there, we have more and more, and I kind of saw that we need this as a prevention problem. Like, people are not going back into their villages and telling others not to do it. There is both a stigma and yeah, it's hard for people to talk about this openly. So I started doing research, looking at how many of these we had, and did actually the world's largest study on about 700 of the patients throughout the 5-year period. On this, mapping all the symptoms they have, what kind of treatment we did, which is basically a surgical treatment where we have to remove all the skin around the penis and then transplant from the thigh. If you want to learn more about this, you can search up my article, but I just have to say there are pictures in there, so be advised.
Fair warning. So going in on that work, I know that, it wasn't just, you were pretty involved from beginning to returning to working to prevent this. So you identified the problem, you looked at the scope of the problem. And then, if I remember correctly, you actually went and created public service announcements around this. Can you tell us about how that evolved?
Yeah. After actually getting to know how big this problem was, because they didn't even know in the clinic, because of course there were written journals, markings in books, so we didn't have the statistical overview of how many people came in with this problem before I started to write this down. And after making this, we had this whole discussion on how to prevent. And my sister is a graphic designer, so she got the brilliant job of putting together, or we put together, a brochure showing basics of men's health, which is taboo and not much talked about here, which I found out that women's health and reproductive health is a very known issue and thought throughout the health, or it's more preached around in the villages, but men's health or men's sexual health are not a prioritized area. So we made this brochure, which is still used in in sexual education around the villages and in Burma, which is really great. And it's also in the article.
That's wonderful. And just to dig into that a bit deeper, was there any initial resistance or shyness, or as you were saying, this is taboo, and it's what I think some of that's universal, whether we're dealing with a clinic in Norway or Canada. For some reason, people are embarrassed to talk about sexual health, but particularly in some cultures here, it seems that men's health was, kind of the word that you can't say. How did you handle that initial resistance, and how did you overcome it?
It has kind of two aspects to it, because on the one hand, this is, like you say, taboo and difficult to talk about, and on the other hand, it's self-inflicted. So if they went to a normal hospital, they would not get any help. You would need either insurance, and even those wouldn't cover self-inflicted harm, if you say it like that. So the taboo was not just for the people coming there, but those working at the clinic. So I think it was the second time we had this kind of sexual men's sexual health education for those working at the clinics, so they could talk to young men and ask them, like, have you heard about these kind of penis injections? That's not a good idea. And here are some alternatives, and other things, like don't put oil into your penis. But then I came back the second time, and everybody was like, or I was asking them, like, how is it going with the education? And they were like, no, we can't talk about this. Like, this is difficult. And that's when we started making the brochure to make it easier, or just the way that they could give the brochure and then people could read about that, and then have that as an opener for asking questions and getting more into what's the problem actually is, and showing the symptoms, showing the problems that this practice can lead to.
Yeah. And it's, you were able to go from identification to saying, hey, let's do something about this. So over what period of time did you follow up on this project? And then were you around long enough to start to see the fruits of your public health labors? Did you see any reductions, even by word of mouth?
I would love to go back and see that. I was following up until 2017, and after that, I'm not sure actually. I know that they are using the brochure inside Burma for education, but the new numbers would be interesting to see. But I don't really know, and it's very difficult because it's not just to take the statistics out. I would have to go there by myself and see through the books and count it up.
Yeah, exactly. And then even broach the topic and then see, what is the reduction and what was the most effective way? Was it the brochures? Was it, screening in clinic? Was it following up X amount of time after having kind of planted the seed that's saying, hey, there's other ways to do this? That's so... Exactly. That's so fascinating. And again, there's, no matter what corner of the world you go to, there's always going to be something that's very cultural that's going to find its way into medicine. So let's step back a little bit and talk about your background as a whole, because you've been at all ends of the spectrum when it comes to extreme medicine. Where else have you been when it comes to offshore disaster tropical medicine?
I was working slightly in Burma, in Uganda, with childcare and vaccines mostly. Mm-hmm. And it's mainly there and outreach around in Karen state in Burma, doing outreach in villages. Mm-hmm. So humanitarian part, it's mainly those areas. Yeah.
How do you approach that sensitive sensitively. As we once upon a time, it was sort of, I think we approached global health in the wrong way, saying that, hey, I'm going to do good for these people, but unintentionally approaching it as a savior type agenda. And so, based on your experience, you were there on the ground. How did you work with the community to make sure that this was long-lasting impact, and also making sure you had buy-in from the communities you worked in?
It's really a good question, and these are often problems with humanitarian work, that a lot of people, organizations, NGOs want to do good, but they don't really know how, and they come in and throw money on the problem and think that's good. But you kind of have to either get to know someone in the community and learn what are the actual needs here, like what are the long-term needs, and you need to build that up. You can't come in, fill the gap, because then the gap is going to be there when you travel out. And that was what I learned, what can you say, the hard way the first time when I came in. I did help out with a lot of things they didn't have from before, but when I left, it was back to the same. So that was when I kind of saw that this problem has to be handled differently, and also seeing a lot of examples from other fields of humanitarian work. For example, building a child care center, but not having the people to work in it, or not the money to follow up, so you actually have staff there for the next 10, 20, 50 years. So there are a lot of sad stories on that, people coming and giving to communities, filling a gap with themselves, and then traveling out. And just like you say, there's not any follow-up, long-term thinking.
And once you said you learned this the hard way, how did you take this forward to your next, your next location? What would you do differently, or how would you bring this up with the team, to make sure that, you learned and were also applying these lessons learned?
Yeah, so when I was there on several occasions for about 3 months, and I think even from the second time, I kind of saw that I'm not doing much by coming here and providing for a few patients during that time, but I do more if I do education, if I do outreach and making brochures that can be used for the time I'm not there. And also it's a lot about motivating the people there, that they're not forgotten by the world. So all these things kind of matter, and it's so important, like you say, to follow up on that field, and not go anywhere, help, go back, and then forget about it, because the people are going to be there, and they need the motivation to keep going, and to build up what's not around.
Yeah, that's a really key point you've hit on. Did you find any strategies, and perhaps it's different for every culture and every group and every minority that you're dealing with? Did you find any particular strategies that were effective for building rapport?
That's a good question. I think that, well, education is the key point. But firstly, like, educate yourself on the cultural things and how things work around the clinic. So I guess a lot of humanitarians that come to rural clinics stamp in, and then take with them everything they know from their hospital, from their way of doing things, and try to implement that. That might not, or usually from my experience, it's not the way to do it. But being there, working alongside the staff, starting to do some milder education on some fields, and then getting this bond that, yeah, you're on the same page, you're on the same team, and then, yeah, educating them in what they need, not exactly, yeah, and anything else. If you see, like, don't bring your interests in there, because that's like, I had this whole mental idea of how it would be to travel out, like what would I need to know to deal with this, and then I came out and I kind of saw it's very different than I expected.
I think, that's kind of the theme that comes from everyone. You can always have a plan, but you have to be ready to change that plan once you get your boots on the ground. And I'm sure that you've had that experience across all these domains that you've been in. So let's talk about your time in maritime medicine. Was this before or after? How did, what were your experiences there? How did you get into this aspect of austere environment medicine?
I was working as a GP, and as your interest is in expedition medicine, austere, isolated environments, like the most isolated we have here in Norway are of course Antarctica and stuff, but also all the oil rigs we unfortunately still have. So a lot of work from there are to follow up what kind of medical help, and also screening everyone who's going abroad, either seafarers or offshore workers, to prevent, disasters happening out there with the personnel, because they have very limited resources. On one big oil rig, there could be one intensive care nurse, and there could be a doctor covering for 3 to 5 fields, which is not nearly enough. And there are always some with medical training, but this is also limited. So trying to prevent things from happening, just like in space, just like in every austere environment before every expedition, prepare and mitigate so the problems won't happen. And this kind of hit me as a really cool thing in medicine, that you can actually do preventive medicine with a bit different population that's not yet patients.
That's really astute, and I think that's really key. That prevention, it's going to be so much more powerful and save yourself so much time and effort later on if you can, look ahead of what's coming down. Now, with the type of medicine you practiced, what would you mostly see on the rigs? Would it be trauma? Would it be mental health? Would it be some combination?
It's a lot of minor trauma, because this is very physical work. Like it's drilling, it's large equipment, it's the whole sea environment, which is really, really, trying to kill you. Sea water, you have, and oil, when there are spills around. So this is very much physical work, which causes injuries. Like mostly that's the problem. But of course, like in, as we call it, extreme medicine in extreme environments, you also have all the normal stuff. So you can't prepare yourself enough. And as everywhere else, like the most usual problems will be the most usual problems there as well.
So once you establish this pattern of minor trauma on top of everything else, what types of interventions would you bring into play to help, lessen the workload later on?
In this environment, it's about training. Basically, like we do here in Norway, we try to do peer training, so everybody has a general idea of what to do when something happens, like basic first aid. And here in Norway, we are on the world top of teaching CPR to the general population. So even from the beginning of school age, kids are taught how to do basic CPR. So we have the quickest time of peer CPR training, and I think it's exactly the same there, giving everyone a basic idea of how to do first aid, and especially with major, minor, or major trauma, and also then everybody will have an idea on how to help out when something happens. Like I say, there could be one to just a few health personnel on this rig, and then they might not be available, or at least if there's an accident and there's several injured, they would need help from everyone there. So there's also training before you go out, so where everybody has to, be a part of the response to a larger accident happening. So everybody gets these trainings out there before they are really even allowed to go out.
So it sounds like that team training aspect is critical to keeping everyone safe. With your resume, how did you go about going from one field to the next? Did you know from the outset, hey, I'm interested in tropical medicine, expedition medicine, all of this? Or would you be in one field and then say, okay, I've gotten what I want out of this. Now I've heard about this opportunity in aviation medicine. Where did you go to next after that? And how did you do it?
As I said in the beginning, I think it's kind of evolved, but also being a positive yes person, jumping every opportunity that felt interesting, that seemed interesting to me, kind of gave me this not linear career path, but a bit of this and a bit of that. And when I look back now, it all makes sense, but kind of like you say, I didn't have a clear idea from the beginning. I didn't follow a straight line, but more following my interest points. And like I said earlier, I wish I kind of was asked that question earlier, like how do you want to work? And then I would have a more clear idea of course, I love to work in the mountains. Extreme pre-hospital medicine, emergency care is brilliant. But I had to do these steps to kind of find out the fields you could, or how you worked in the different fields. So it took me some time doing a lot of small, of course, fun things on the way to kind of grasp what I really wanted.
I think you're spot on. All too often where we hear follow your passion, and for those who know what their passion is, they want to be a cardiac surgeon from the day they're born. That's fine. But I think the way that you've approached it, fact finding, saying this seems interesting to me, let's pursue this, say yes to this, and knowing that you like everything, I think is a good way to go about it. How did that bring you to tropical medicine?
I guess that was the humanitarian aspect, and also the interest in travel and learning about other cultures. Because as cultures evolve, it's a lot around what's happening and what's the problems and what are the potential problems. Like in Burma, they build houses on sticks because the flood is coming. and with the flood you have diseases. So all this kind of learning to understand a culture, you can do a lot with medicine. So traveling and working was my kind of main go-to. And I love Southeast Asia. I love Burma. So tropical medicine, and also in Africa, became kind of the most interesting. And they have the most, I don't know, scariest diseases out there as well, with all the parasites, worms, etc., which are both terrifying and extremely interesting.
So I will agree with you. Yes. There's some Instagram accounts I follow on tropical medicine that are both too fascinating to look away from, at the same time so horrifying that you hope you never run into it.
Absolutely agree.
So with that, let's talk about your interest in pre-hospital and disaster medicine. You hold a master's from leading European institutions. So what geared you towards this, and how have you focused your time since obtaining that master's in disaster medicine?
So when I was in Myanmar, of course, this is a conflict area and has been for a long time. So the second time I was there, there was huge conflict going on in Karen state, and seeing this kind of the disaster happening, thinking about how we prepared and how we responded to that, gave me a keen interest in how to respond to, how to prepare for, how to simulate and train for any disaster anywhere. And I was also working at the Oslo emergency ward when the bomb hit Oslo in 2011. So also from working in that kind of environment in Oslo, this was the same as the island shootings, and also working up after that with follow-up of families and also the whole community that this had inflicted, wounds and trauma that would stay with them forever. I find this very interesting. So that's what led me into the master in disaster medicine, which takes everything from risk assessment in the beginning, trying to prepare and making plans for preparing what kind of equipment you need, etc., to the response in itself. We did a lot of big live exercises with the Italian military and the Red Cross there during this training, and then afterwards writing reports, looking at lesson learned, what went wrong. I remember one big exercise we had in a tunnel with ammonia tanker that crashed with 2 buses and 3 cars, and we had 120 casualties. Which this was a live exercise, so we had med students with makeup, and everybody had their own role. They were a person acting out how they were terrified, like who they missed, what kind of problem they had. And in all these kind of big exercises, the biggest lesson learned, the biggest problem is always communication. It is inside or it's towards the hospital, it's with the police, fire, and the health personnel. It's always communication, and this is what you have to train and drill. You need these big exercises with all the personnel who is going to respond to a major incident. You need those together, and you need to train together. So this is this is what I learned. And also using, I would never think about having a pandemic happening in my country and now being part of that response here.
Yeah, we're going to talk about your COVID work in a second here, but I want to get some more of your insights on communication breakdowns, because that is so interesting to so many of our WEM audience, who deal in all manner of austere and highly operational environments. Where do these communication breakdowns occur, and what kind of fixes, in your experience, help mitigate those breakdowns?
So closed loop communication all the time. When you get a message, respond back the message, so the person giving it know that you understood it. And when it comes to major incident responses, every country, every part has their culture, you can say, also for communication. And this is often difficult to cooperate if you haven't had the training together. And this was a big thing during the response in 2011 in the bombing and the shootings in Norway. And afterwards, we got the same kind of communication equipment throughout, who made it much easier to communicate between fire, police, and the health response during a major incident. And the thing is that this was not a specialized system for major incidents, but this was the system that was used every day. And a learning point is to, in an extreme situation, I don't have new equipment to use. Like, use the thing you use daily. And when it comes to communication, like, use the communication systems you use daily. And if that's not good enough, take the things that you're supposed to use during a major incident and use that daily. So when something happens and your brain is going to freak out because of the incident, you know what you do. You have drilled through this. You have simulated and tested and done all the mistakes before you're in that situation.
Yeah, that's exactly it. It's that red telephone analogy. For using a black telephone every day of your life, don't use the red one in a crisis.
Exactly.
So, for those who may not know what the closed loop communication looks like, what does that look like to you?
So an easy example is if I need help with something, like I need you to bring out adrenaline, I would say, I need adrenaline. You would respond back, I will go get the adrenaline. So it's basically repeating back, not just saying yes, and then I'm not sure if you really got the message, but repeating the message back.
Yeah, maybe I heard noradrenaline and bring you back the wrong thing. So yeah, that's exactly where my mind went too. It's a code situation. It's exactly, 50, like one of epi in, one of epi has been put in. So, it's so key. The other thing I want to know about your background is you do so much, not just medicine that's extreme, but you do all manner of extreme sport. You're into mountaineering, skydiving, you're a rescue diver. These are all very operational, dynamic environments. Are there lessons that you've pulled from your experiences here back into your medical practice?
Oh, absolutely. There is. And I would say prepare. Like, prepare mentally and physically. Know your limits and your environment and your equipment, and prepare for changes in all that. So being in environments that I'm not what to say, comfortable in or not used to be in. Knowing the equipment you have and also knowing your limits is of major importance. I remember one time we did this medical expedition inside Burma, and it was during the monsoon. So we had this hard rain on the roof all night, and we're sleeping on bamboo mats. And we were doing surgical outreach mostly, and it was all daytime. But one night we had this young woman coming in, and she was in labor. And I remember I was in no way prepared for this. Like mentally, I was not. So by the time she come in, I started just overthinking. And before I got my med kit out and fresh water, the baby was out, and I just overthought. But while my colleagues there and the medics, they were kind of, not overthinking. They were mentally prepared for something could happen at any time during the night, etc. So even a procedure I was familiar with during daytime, I was just not in that mental room of this happening. And I was also exhausted because of the rain and not getting enough sleep. So having that kind of thought and taking care of yourself during an expedition or during this kind of outreach work is essential. Actually taking care of yourself was, it's not that long ago, this was taken into the doctor's oath. And I think that should be in every field, that taking care of yourself, you have to put on your own mask first, right? You have to take care of yourself before you can take care of others. So this is something I really learned a lot from, this being not mentally prepared and then overthinking. I think and the way to mental prepare, like doing exercises, back to the disaster medline, doing live big exercises so you mentally prepare yourself how situations will look like is really important. And it's just there you can learn a bit how to improvise, but also in the idea that you have a mental image of what's going to happen. You can also make yourself a plan B, a plan C, and then if things doesn't work out, you go to plan B and they work out, or you go to plan C. So I think in that way, that stress prevention you can do by yourself going through what is the worst that can happen when something is about to happen, or when you're on call, or you're in an environment where something could happen, is of major importance.
I wholeheartedly agree with you. And maybe this is something that we should work really hard to bring into, early medical training, is that mental rehearsal, the contingency planning, and most of all, that self-care, that you can't set yourself on fire to keep someone else warm because there's only one of you. And I think that's super relevant now in the era of COVID and the pandemic. And, life is so different for so many of us. And I know you for a fact have had to switch tracks like many of us. You've done some very critical work at Oslo Hospital. So tell us about what you've been doing during the pandemic.
Yeah, so before the pandemic, I was working as a GP and some in the emergency ward. And I had a year planning for doing training in space medicine. But then COVID hit. It hit Norway in March last year. And I was quickly engaged in putting up the tents for testing, and also in coordination for tracking the disease spread and how to make a larger response. We had the shutdown of the whole community very, very quickly, and luckily everyone followed that. So we were able to control the disease pretty quickly. So having a few waves after that, but during that, I've been mostly engaged in the infectious disease department, both following up patients and also doing testing or coordinating testing and tracking the disease. And this is actually really, really interesting because you will have these small kind of outbreaks here and there, even when you have a low number of people with COVID. And it's so important to kind of track down everyone that has been in the environment or together with this one person to stop the spread. So we having people being very cooperative with giving out who they've been around, and people also isolating themselves. And also for the last months here in Oslo, it's been advised to only be together with 2 persons at a time, and maximum 5 to 10 during 1 week. So it's been really harsh, and I think a lot of people around feel that as well. That now it's kind of enough, but it's so important that we follow this, because this is taking its toll, and a lot of countries are really, really struggling at the moment. So I would say we've both been lucky, and we also had a great response here in Norway.
Yeah, it sounds like you, at the bigger picture level, did a good job of, preventing spread. Has that changed at all with the rise of variants? Have you found yourself in more dire straits, or because you're maintaining these strict distancing and lockdown measures, have you been mostly okay?
There was a bit discussion to open up more before the mutations hit just over Christmas, which led to a new shutdown. And it's basically, at least in the major cities, it's been a lockdown more or less since New Year's. So this has been harsh. Like every shop is closed, all restaurants, etc. And it's been really important for the spread. It was a big discussion on the borders, because we have a lot of work travelers coming into the country, and that's kind of needed for the industry and also health workers, which we are reliant on. So it's been a big discussion if we would close the borders totally, or how that would be. And that has absolutely changed after the mutations. But also how we see the disease, like sometimes it almost feels like a new kind of disease. The way it spreads is very much different to what we were used to from March until Christmas. Like even in a household, or people being around, they would not get sick if they were doing proper hand hygiene, keeping distance, etc. But now we see a lot more spread from one outbreak than we did earlier.
Yeah, it feels like things are constantly changing. We still have to be on our toes, and we still have to, as you say, keep thinking about these contingencies, because yes, we have vaccines now, but now there's variants and there's double variants. So it's exactly as you say, keep being prepared. So the other thing I want to touch on is that you have embarked upon a PhD this pandemic, doing interesting work with biosensors, which has application for both the pre-hospital care and potentially for COVID care. So tell me about that.
So this is a project that started out from Oslo University Hospital, from the National Advisory Unit for Prehospital Emergency Medicine, where I'm engaged now in this PhD. So it's about home monitoring during and on COVID patients. So as this is a research, we randomize the patients into two groups. One group is followed up by us through a self-reporting form, and the other one gets a lot of equipment, and they get pulse oximetry, which measures the amount of oxygen you have in your blood. We have a temperature, blood pressure measurement, and we have this bed sensor, which is the exciting bit about it, that can actually measure pulse and respiration just by being close to the mattress. So it actually measures the waves the body sends out, a bit like Newton's third law, where you have all the balls and you slip one and the other pops out without all the other moving. Like we measure the waves the body sends out with each heartbeat and respiration in the mattress. So this has implications also to being able to measure through clothing. For example, in the winter in Norway, we can use this pre-hospitally to at least get heart rate and respiratory rate, and from that heart rate variability, and we have a calculated stroke volume, which we are now working into actually giving us a cardiac output, which is really exciting, because then basically have the blood pressure measurement without needing to undress people to put on
Wow.
a measure.
That is very novel and game-changing. What's your threshold right now for distance that away from the patient at which you can detect these parameters?
This is the kind of difficult part with these sensors, because they are extremely sensitive. So they can be, what you say, you can have several layers of clothings, an over mattress, and then the mattress. So the distance is not really the problem. It just has to be like this ball in this experiment. They have to be in touch with each other. So actually sending the waves through all the material. But with being so sensitive, it's also a problem with noise. Because if any of these materials are scratching on each other or just moving, that will represent in the data. So we have a lot of work ahead of us to actually be able to implement this properly. But yeah, we are now using it for on home monitoring, and that works for heart rate and respiratory rate, which is hugely exciting.
Wow.
And also an important work, because in the beginning of the pandemic, we saw that patients were isolated in the basement part of the apartment or the house, or in their own separate rooms, and not with the family. So the family wouldn't see deterioration in the patients like normal, and a lot of the patients we were admitting at that time was really, really ill. So we needed a way to see how, or kind of how to predict when the patient would get worse, and then as early as possible admit that patient for observation in a hospital unit. So this is actually what we are doing now.
That's awesome. Both the technology and the way you've pivoted, from everything from early detection of poor outcomes to now that we know about the severity of long COVID and its implications and follow-up, there's so many directions this could go. So that's, kudos to you for embarking on this work. So in the final minutes here, we cannot get away without talking about our mutual love for space medicine. You and I, we have had amazing adventures together, whether it was, walking the streets of Edinburgh at the last in-person WEM conference to spending 2 weeks in the Mars desert on a simulated Mars mission. How did your love for space start, and where are you going next with that?
I think that started from when I was young, looking up at the stars. And I remember getting all the stories about Northern mythology and Greek mythology represented in the stars and the planets. And also how the environment is so different, but the minerals and where everything comes from is exactly the same throughout our galaxy. And learning that how small we are kind of gave me an awe to being also minor, but also part of the whole thing. So having this love for space and the whole universe, I think that's always been there. But it wasn't until going into extreme medicine and being at the World Extreme Medicine conferences, I kind of understood that this was actually a career path, and this is actually something you can work with, and there are others also working with this, because human space flight is not a big thing in Norway. It's not prioritized. We are sending up a lot of satellites, and there's a lot of research on space, how to get minerals out. We have a module on the Perseverance doing radar for looking for water traces, etc. So we have a lot of big technology out there, but human space flight, not that much. So I'm really working now to kind of build up that, and hopefully in this application period we'll have a Norwegian astronaut. Hopefully.
Are you going to apply for the European Space Agency application?
We'll see. I'm more of the guy that would be behind and supporting those going up. But we'll see. I leave that question hanging.
Well, we're definitely going to have you back for a part 2 if you are the next Norwegian astronaut. But thank you so much for your time today. In closing, I want to ask you, are there any bucket list items on your extreme medicine wish list as you go forward through your incredible career spanning all manner of extreme medicine environment?
For now, it's been a year of not much happening. So I am going back to Svalbard, which is one of the more extreme isolated places in Norway. It's a small island between Norway and Greenland. And I also have family on Iceland. So as soon as they open up a bit, I'm going over there and I'm going to check out the volcano, which is currently going. Currently spitting out lava.
Wow. Okay, so you really are.
And yeah, it's such a long list, So we could be talking for hours, but that's at least the 2 first things.
I approve. A volcano is exactly what I would expect from your career so far. Dr. Johannes Svensoy, thank you so much for sharing your expeditions, your experience, your lessons learned from all manner of operational environment. For anyone who wants to find you, follow your lessons on social media, where can our audience learn more?
They can search me up, Johannes Svensoy, I'm not that much on social media, but I have a Twitter and Instagram account, so please follow.
Perfect. So we will make sure that your links are included in the show notes. Thank you again so much for making the time today. As always, thank you to the audience for joining us for today's Webcast podcast. And to learn more about our organization, what we do, check out worldextrememedicine.com. Leave us a message on social media. And until next time, Dr. Shawna Pandya, looking forward to the next episode.
Thank you.